Other questions? Hank?
What would you think, this is Hank Wernick from Wernick Consulting, what would you think about the device industry itself undertaking an initiative which I would call medical quality cost management, in which it tried to combine the clinical quality dimension with cost management, where cost is broadly defined as more than the cost of the device, but also some of the associated costs. And in this, study existing device technologies and try to come up with a set of methodologies which could then be embedded in the thinking of future product development, as well as input to the reimbursement decisions, to educating physicians, and also with this in mind have input from physicians at every step in the process, as well as input from the private insurance kind of thing. What I have in mind is taking a lot of the work that InHealth does under Martin's leadership and really putting a new paradigm around it to look at not just the medical quality, but medical quality cost management. What would you think of that idea based on your...
I'm not sure I fully understood the idea, but I think what you said was, and which I would be in favor, because I'm currently doing it, which is to develop a framework in which you could have this kind of evidence channel in a rational manner into payment policy. That's, I think, is the big missing link. I mean,
for the device industry.
Yeah, exactly, for the device. No. I mean, I don't think it's understood for medical or for drugs either. So I don't think devices are unique in that way. I think it's poorly understood across the board. But I think in order to, help the patient to get the right treatment as opposed to which treatment is better, I think you need to develop some kind of framework that people can make those kind of judgment about which products to use, which is currently not, I think, in what people have in mind now. People now have in mind that certain treatments are wasteful relative to other treatments, and we should therefore lower coverage for those treatments. That's what comes out of the Dartmouth line of research. That's come out of some other research which I think is very fraudulent, claiming that there's so much waste in the healthcare system. I think that's somewhat absurd that we can be wasting, such a large share of GDP all of a sudden, but that's a different topic.
Other questions? Yes.
Steve Brent, University of Minnesota. Tomas, let's see if I get this correctly. Are you advocating that there should be a decision aid for both joint decisions of patients and consumers, ideally, that's evidence-based, as opposed to an insurer, public or private, more or less saying yay or nay, kind of like the UK NICE's decisions, to get to an optimal outcome?
No, I think the market will take the evidence and run with it. I don't think you can control really what patient and doctors do, okay, or how they use the evidence. I think that would be unlikely to be able to control that. But you can certainly control how rational payment policy is made based on evidence, which now is, we're not going to pay based on this evidence, which I think is
right.
Very strange policy. And that's not going to be consistent with the facts once this evidence comes out.
So I'm just thinking about, years ago I worked for an insurance company, and and actually did med tech assessment and looked at various evidence. And when it actually came down to very simplistic decisions, it was sort of yes or no, do we reimburse it, or would it be pending medical review, meaning that it would be covered, but only with the permission of an associate medical director that effectively reviews whatever evidence is available to them. I'm just thinking about operationally.
Yeah, we were actually I have a company called Precision Health Economics. I'm allowed to make plugs at meetings like this. But we were asked by the Kennedy Commission on commenting on their work in the UK when it came to revising the NICE standards. And what I said that wasn't very popular, but I think is very true, which is what I said is it doesn't really matter what you do here. Innovation is not going to be affected by what you do because you're 3% of world sales. If the U.S., on the other hand, did something like NICE, it would have huge effects on innovation because most of your profits are made in the U.S. I mean, for drugs, I don't know what it is for devices, but for drugs, more than 50% of sales are in the U.S., even though U.S. is only a fifth of the world economy. So the U.S. actually have an innovation trade-off in setting their evidence-based policies, which NICE does not, because even if we shut UK down, it wouldn't affect innovation. And so UK does influence a lot of other European countries. A lot of other European countries do come in and just mimic what NICE does, but that doesn't add to it's like 15 or 20% if you add that up. But the much graver implication for innovation comes into the U.S. So cost-effective things are obviously not good things in the long run, because if we priced at cost, we could just eliminate patents, we would have a lot more cost-effective healthcare economy. Presumably that's not something we want to do in the long run, but you have a real innovation trade-off. You shouldn't have cost-effective treatments in the U.S. That would be huge damage to future generations. So you're trading off not only buying cheap today, but what you want to have on the market tomorrow. And there's really an intergenerational trade-off in the U.S. of setting evidence-based payment policy that's not existing in the role model of NICE.
Other comments or questions? So what you're suggesting is that the American taxpayer should bear the burden, if you will, of subsidizing the medical device industry as a public good in terms of innovation, and that the rest of the world, as in the drug market, the pharmaceutical market, I should say, comes along as a pretty much potential free rider.
I'm not saying that's a good thing. Ideally, I would want market prices in other countries. That's what I would advocate. And they have, regulations to go below market prices. But if Europe lifts their prices to market levels, presumably U.S. individuals would be, or my generation or my kids' generation would be better off. Current Medicare population probably didn't have time to be better off from future innovation. But given where we're at, I'm not saying that I would think it would be worse to not have a subsidized world innovation, because our future generations are clearly going to be hurt if we do what NICE does.
Okay. Well, thank you very much for that provocative discussion, and also thank you very much for getting us back on schedule. So we're going to take a break, and we're going to resume at 3 p.m.